These pets don't
Okay.
go up to
And kinda go
18,
start to
so we
finish,
just keep them
And
on
then you're gonna
12,
see a
or-
few different things, and always remember, some steps may be skipped out there. How many of you saw an Allen's test before each ABG puncture?
I was told about it, but it was not done.
You were told
Is
about it,
it
but it's not
every,
done.
before every one?
You are supposed to. So that's how we
So it's
teach
the
it.
main one.
Now, I'll be honest, how often have I? It just depends on the person and et cetera. If there are some, other issues, I probably will to decide right or left. But bottom line, it's as we'll learn in class, because we're gonna start on gas exchange, it's a relative contraindication. If you have pretty poor pulses in both sides or blood flow, you're gonna have to pick one. So it's not like you can just say, oh, we're not doing it. Okay? So, check off first, and Brian's gonna be my arm, so that's how it's gonna go. You will, the instructors who will be checking you off on the ABG puncture will be the ones that you're gonna do the Allen's test on, because obviously our arms don't really have flow, so they won't do what we want them to. Okay? So I'll go through it first, hopefully without stopping. All you have to do is just look at me if I go off, and then I'll just focus again, and then I'll go through it again just to kind of go step by step as to what we're doing. Okay? Check your orders. We always say check your orders, but really, really important in this situation, because it's one thing to give a Metaneb to a patient, to the wrong patient, but it's really a whole other ballgame to stick them, because it's an invasive procedure. So that make sure that you are doing this on the right patient. Okay? So double check your order, double check to make sure that it's ordered. Is there a specific liter flow? Do they want the patient on room air, or is it on whatever they're on already? Walk in the room, all the preliminaries, knock knock, here's who I am, here's what I'm gonna do. Wash your hands, and then talk to your patient and go from there. Okay, so as you walk in, gloves here.
So, and guys, with the ABGs, we do not draw femorals. Only doctors can draw the femorals.
Depends on the facility.
Well, yeah, depending on your facility. So you also have to be aware of clinically in different hospitals that you're in on where you can go. So, you know, if they have a port here in their arm, probably not the best to go in this arm, but you have to be able to go to each side. So that's kind of what she's talking about, is you can't always go to one side. You kind of have to deal with how the patient is. So, and you'll see it clinically, like they'll have a bracelet that says no lab draws. Well, sometimes you have to draw from that. You have no other. So it's kind of like case by case, each person. So, and we'll go through that in clinics with you.
So what's the point of the no lab draws if sometimes you do it anyway? You know what I mean? I guess what are they
Because
trying to
that's
prevent?
all, your lab draws mostly are done venous.
Oh, okay.
So that's why it'll say no lab draws here. It is a lab draw, but we're drawing arterial. So that's your last option, but if you have to, you have to.
Is it usually a clotting reason why they don't want lab draws? I guess what is it?
There's
a lot of reasons.
There's a couple different things. We're not gonna get too far, but you should always check your clotting factors too. So.
Do we have any Cobain? I was trying to find that. I know we have at least one.
I think for me to get the full effect, you should actually stick Brian.
Well, I think mine was the last class, because I remember we stuck each other.
My instructor was telling me that yesterday.
Well, whoever was willing. I was
Yeah.
not.
Yeah.
I was
No, I
willing to
wouldn't.
stick. I'm like, to this day, I still, my stomach turns. I can't eat if I have blood work.
I have
done.
rolling veins though. Do you?
Yeah.
I'll be
That was
fine.
what was my mom.
Go
Her
fishing,
blood,
girl.
like, when she gave blood, because she always got snacks, and so I ate them too. When I was little.
Yeah.
Snacks.
Yeah.
You're so
Yeah, like
When I went to paramedic school, we had to do IVs
I
on
know,
each other.
it was last year.
Some
Yeah, like that was
paramedics
only
do
6
I
months
don't do
ago.
needles.
To give you a historical perspective, I
I
had
mean, I
lunch
have the
with
best babies.
my critical
Yeah.
care teacher in Louis last week, and we were just discussing how back in the 80s they would intubate.
No way.
Like each other.
Well, not each other, but he would. Can you imagine that? I mean, I'm just sitting here going, oh my God, I cannot even comprehend a world where we would do that.
Right, like poking a needle is one thing, but like
Speaking of blood, yeah.
intubating somebody.
Yeah, Dad told me that when he did it.
Again, if you volunteer.
I mean, I guess.
I mean,
I mean, we did see a video of it, so.
Well, I've
Like
had
I said, it's
bronchitis,
not.
so, yeah.
Anyway. All right, so, knock, knock. I'm gonna wash my hands. I've checked my orders. Good morning, Mr. Jones. My name is Sonia. I'm here from the Respiratory Care Department, and I am here to draw some blood from you.
Okay.
This is gonna be a little bit of a different blood draw because it's going to, I need to get blood from your artery. So I'll talk you through the whole process. And after I've checked your ID and you've told me your date of birth and verified that it's the right patient, I will go ahead and get all my supplies ready. What I'll end up doing is using the needle to probably go right here or right here. And as I mentioned, it's a little different from getting blood. You probably did that this morning because I have to feel for the pulse and go where I feel an artery, the pulse itself.
Is it gonna hurt?
Well, I'm not gonna lie. It may. It's not the most comfortable thing, but no sticks really are. So, like I said, you talk me through it. I'll talk you through it, and we'll get it done. Okay?
Okay.
All right. So I'm gonna get my stuff ready. Before I do that, I just need to double check and see how your flow is, and make sure that I'm sticking the right arm. What I'll need you to do is, go ahead. There we go. I need you to kind of pump your fist like this. And in the meantime, I'm gonna occlude, this is your radial and this is your ulnar artery. And I'm gonna occlude it, so kind of, there you go. And at this point, I am going to let go and just relax your hand. And it pinks up. Good. So what I'm doing here is when I occlude your radial and your ulnar, those are the two major arteries that supply blood to your hand. I stick in the radial. If for some reason I damage that, FYI, I would not say all of this, I'm just saying this so you guys would understand what I'm doing, that the ulnar artery is intact and it will take over providing blood. So that's why I let go of the pinky side, okay? Just for the hell of it, let's do the other hand too. All right, let's do the same thing again. Fist. Keep going. Keep going. Keep it open, keep it open. And it pinked up already. We're looking for it to pink up in less than 10 seconds, okay? So I'm gonna still go ahead and draw on this arm, which is this one right here. I'm gonna go ahead and get my stuff ready.
Mm.
You said you're looking for the skin to pink up, the skin itself, where you press like a figure like capillary refills
Yeah,
does?
same,
Yeah, that's
same
what
type
it's
thing. You're gonna
doing.
see it go white.
Cutting off that circulation.
Then when you release, it'll pink back up, showing that the blood, the same thing as like the cap refill.
How do you do that on a minority?
Trust me, you'll see it.
It'll still
You'll
turn
see
white.
The palms of the hands are still white, so, or pinkish, so you'll still see it.
There's still some data
Mhm.
with it? Awesome.
I'm gonna get rid of the iodine, I don't need that, I just need alcohol prep. All right, and I just put a label here with your name and date of birth and all of that information.
And like she said, make sure you check the order that it's the right patient, because I've seen them put it under the wrong patient.
Jesus, switch chairs.
Okay, I'm gonna look, oof, can you tell me? I can see it.
It's facing.
Yeah, where's the
Bevel.
bevel?
Point is
Bevel.
your
Right there?
direction,
Okay,
yeah. Right there.
so the bevel up, because we will be sticking here. And what I'm gonna be doing is sticking at a 45-degree angle. But before I do that, I am going to wipe off the area. Always wipe off your hand too. Try it out. And I'm feeling for a pulse. Okay, I feel a really good strong pulse here. You are going to feel a stick right now. And you see a flash, you allow it to completely pump up. we will at least fill one out with fake blood so you guys can see it. And when it's completely filled, you're gonna grab your gauze, pull straight out, and hold a lot of pressure. At this point, you're going to, this is your safety, so always do that first. And now you're gonna hold pressure. If you're able to hold pressure and at the same time, take this off. You're gonna need to twist off the, twist it on pretty good. There you go. And then you're gonna put this cap on. I'll show you in a minute what that means. You're still holding pressure, but I'm perfectly fine with you holding pressure and letting me know that you've held pressure for a good 5 to 10 minutes, depending on the patient, depending on if they're on any anticoagulants. And then you're gonna take a look, make sure that you don't see any bleeding before you put the Band-Aid on nice and snug. So you take care of your patient first. Some places, instead of Band-Aids, will put a Copan wrap around. You know, Kettering does that. The key here is to remember to come back and take it off. So we hold that, so that's taken care of. Here's my blood. And again, we'll go ahead and do at least one arm, so that way they can see. And right now, you have blood in here, visualizing that. With the cap nice and snug on, you should flick it first to make sure that whatever bubbles are in there rise to the surface. And then you just kind of gently push, which will allow it to go right in that cap. I get that it's important we actually have some fake blood. So I'll show you that here shortly.
Blood goes in the cap, or the bubbles
A
are
little bit of
releasing
the
up
blood
in
and the bubbles, because
Okay.
that's what we want to see is get rid of the bubbles.
Okay,
all
so
you're
that
left-
cap is for the bubbles, technically.
Correct.
Okay.
And some blood will be expelled with it. Again,
Right.
I'll demo that here shortly.
Okay.
And then you want to mix it. Okay, mix it all. Put the label on. Now again, in addition to all the patient information, if your patient is on oxygen, you want to put that. If your patient is on BiPAP, whatever the settings are, you want to put that. If they're on a ventilator, you want to put everything that's on there on this label. Some places will have a little sheet that you fill out, just depends on the place. If this is able to be run, for example, some facilities, as you've seen, respiratory therapists run it, so you just go run it and then you're done. You probably don't need to ice it. However, if you're going to be sending it to a different department, you should put this on ice. Okay, and we'll talk a little bit more in class as to why that's important.
And check your facility, because some have stopped doing ice and some still do. So once again, check with your facility.
And at this point, how you doing, Mr. Jones?
That didn't hurt too bad.
Didn't hurt too bad? Okay, well, I'm happy to hear that, because sometimes that's not the case. I am going to come back in a little bit and just check. So I stuck you here, and I'm just gonna check a pulse distal to where I stuck you, just to make sure that the blood flow is still going. Every once in a while, we won't know that we may have spasmed the artery, and if we did that, we won't feel blood flow distally to where we stuck. So this is where you feel that. Okay, again, you're probably not going to see too many people do that as well, but we're just going through all the motions. And then you document ABG drawn from the right radial artery, 0.5 cc's or 1 cc, depending on how much you draw. No complications noted. This was drawn on 50% oxygen, specimen sent to lab. Okay, very important to note, no complications, checked for hematoma, checked for distal pulse, all of that, because then you're essentially saying, when I left the room, I did everything I was supposed to.
How much do you typically want to draw?
Well, interestingly enough, we used to
0.5?
have to do a lot, but really 1 cc covers you pretty well.
Okay.
Which is usually what I do. So I'm gonna open another.
I know yesterday we had the issue of getting enough
Yeah.
for whatever
So
reason. So
typically, it kind of depends on the syringes that they're using too. Some are already, like, you pull the plunger back and it's already set. Some of them pull it back to 1 to 1.5 right in there.
We used to do that. Now you certainly can, then you have a bunch of left over, but these machines, which we used to have that there, the ABG analyzers really need a minute amount.
right.
So like with that, when you only got a tiny little bit, we typically run an
And everything can
iStat then,
Okay.
where it only takes a little tiny bit, but only
'cause
certain
it was,
people
it
in
was
certain
very
areas.
little blood and had too many bubbles for it to
Yeah.
read.